Thank you so much for joining us and attending this live webinar, Preventing Relapse in the COVID Era. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health and Public Housing. It's such a great pleasure to be part of this activity, and we are going to have a really nice conversation. We have a great panelist today, a great speaker, and a great subject matter expert who's been working on smoking cessation for many, many years. Just before the webinar, he told me that he's been working for more than 30 years on, on smoking. So if you have any questions or if you have any comments, please make sure that you ask your questions. And this is a great opportunity to have a live conversation with someone who's been working on smoking cessation for the last 30 years. Next slide. This is a live activity at this moment. All participants are muted. Please, again, if you have any questions, please ask your question. You can use the chat feature, or you can raise your hand and your line can be unmuted. This meeting is being recorded, and the slides and recording link will be sent via email in the next few days. Next slide, please. We are the National Center for Health and Public Housing. We are funded by Rehearse to provide training and technical assistance to community health centers. We focus particularly in those health centers located in or immediately accessible to public housing. However, this training is for all health centers and organizations that would like that are joining us. This is again Rehearse a priority, a hot priority, and it's been a topic of concern for many, many years. And next slide, please. Just a quick reminder, the latest data from UDS 2021. In 2021, health centers serve around 30 million patients. Out of the more than 1,300 community health centers, 458 are located in or immediately accessible to public housing, and they provided services to 5.7 million patients. And 108 of these 458 health centers receive funds from Rehearse to provide services to public housing to public housing residents, and they serve over 900,000 patients in 2021. Next slide, please. Quick reminder in regards to public housing demographics. There are about 1.5 million people living in public housing, and the average of people per household is 2 people. 38% of the household report to have at least one person with disability. 91% are low income. 43% are African American. 26% are Latinx, and 19% are people over the age of 65. 36% are under the age of 18. And 32% are female-headed household with children. Next slide, please. Just to get started, this is a document or a publication from HOT and CDC. This is a joint publication, and this data is being updated, and that's my understanding. HOT and CDC are working to provide the most recent data that they have. I would like to highlight a couple of conditions that are linked to smoking, and COPD, for instance, is the prevalence is almost 2 times higher on the population that is HUD assisted. And there are other conditions that are associated. There can be associated to smoking, or and this condition can get worse if you have people who are smoking, like diabetes, or if you have asthma. Um, so this is really important to know, and just to make sure that the population living in public housing and those who are HUD assisted are more likely to have some condition associated to uh, smoking. Next slide, please. So I am very pleased to introduce our speaker. Today, we are going to have uh, Frank Vitale. Frank is the National Director of the Pharmacy Partnership for Tobacco Cessation and has worked in the smoking cessation field since 1987, designing cessation programs and educating over 20,000 health professionals in how to help patients stop tobacco use, and counseling nearly 10,000 patients to quit. He received a BA in liberal arts from St. Vincent College in 1974 and a master's degree in psychology from Duquesne University in 1988. He entered the field as a health educator, then as a clinical coordinator for the lung health study, researching the differential effects of smoking cessation and inhaled medication on the prevention of COPD in identified high-risk individuals. Followed by becoming project director of lung health study 2. Subsequently, he created a 6-hour CE program, the International Smoking Cessation Specialist Program, designed to teach pharmacists how to do smoking cessation counseling, writing the patient support booklets that accompany this training, as well as all auxiliary materials. This program has been presented throughout the US, Puerto Rico, Spain, and the United Kingdom. In addition, he contributed content material for the RX for Change curriculum from 2007 to 2012. Frank continued to provide cessation counseling training to pharmacists through various projects with the CS Today program. Recently, he designed a cessation training program and intervention protocol for psychologists in Beijing, China, as well as for the HYV grocery chain in 18 Midwestern states. He's currently a clinical assistant professor at Purdue College of Pharmacy, working on a myriad of projects designed to train pharmacists, physicians, respiratory therapists, and other clinicians interested in adding cessation counseling to their practice. So, good afternoon, Frank.
Good afternoon, and thank you. Welcome, everybody. I am in sunny Pittsburgh, where we may get thunderstorms this afternoon. So if you hear a lot of noise while I'm doing this, that's what it is. But right now it's sunny and warm and a beautiful, beautiful fall day. All right, so as you were just told, we're going to be talking about relapse. It's very apparent over the last couple of years that many people who had quit smoking years ago have relapsed back to smoking because of the myriad of issues that occurred over the last few years dealing with COVID. And interestingly enough, many people have actually gone to vaping. So the last session, we talked about vaping. So, if you didn't have a chance to take a look at that, it has been recorded, so you can review that after this. But I want to point out right at the beginning that all the behavioral stuff, everything we're going to be talking about here in terms of helping someone stop smoking, it also applies to helping someone stop vaping, or in any of its 500, 600 forms. So today is, we have to have for our purposes, we have some objectives here that just going to quickly go over. We're going to deal today with the various challenges that individuals are dealing with now that we're in COVID for 2 years. Look at effective strategies to prevent relapse. So my whole perspective here is that if we intervene beforehand with our people who used to smoke, we can actually prevent them from relapsing. Then I'm going to go over some techniques, including motivational interviewing techniques to help people who have relapse to get back to abstinence, and then very briefly discuss any medication modifications that might be appropriate for individuals who have relapsed. So what has happened over the last 2 years? Well, the data is just coming in. There is a lag time, as you know, from in collecting any kind of data. But we do know from these two studies, at least, and from anecdotal information, that there has been significant amount of relapse in the last couple of years. One study showed that 28% of former smokers relapsed last year, and that in the first year of the pandemic, we had a 17% relapse between March and June. So in 3 months, that's a pretty significant amount of relapse. And the many, many, many reasons that were given kind of come down to three. I'm too stressed, I can't deal with COVID. And then being isolated. Many of you who've worked in this field know that many people feel that cigarettes are their friends, are their helpers to get through life. And so being isolated during COVID, just because of the nature of the disease, led some people to go back to smoking as a comfort, as a feeling of having that friend, that buddy there. And then just the general statement that we got, it's just all too much to handle. Everything, it's just such a mess. I need some way to deal with this. So as we get into this, or before we get into it, it's important to understand what I mean and what we generally mean by relapse. And that is going back to a regular pattern of smoking after a quit attempt. So that can be exactly what you were smoking beforehand or a different number, it doesn't matter. It's just going back to a regular routine pattern of smoking after a quit attempt. What usually triggers relapse? Well, this is my own idea. I've always said this, it comes down to 3 Ds. Death, somebody dies. So you're distressed and upset, so you run back to smoking. You get sick, or somebody else in your family gets sick, so some kind of disease triggers it, or disaster. So your kid ends up in the hospital, your house gets flooded, some really major thing happens, and again, you're running back to this product, this thing that you think will comfort you and that you feel has done it in the past. So even if you haven't been doing it for a few years, you go back to it like an old friend. And then COVID happened, and we find that many, many people went back to smoking exactly because of that. So as I said, I want to prevent this from happening. So what can you do? Well, if you're seeing patients on a regular basis, and you're seeing the same patients on a regular basis, then I want you to start right now asking them about their smoking status. Even if you know they've quit, it's still okay to ask. So find out, just say to the person, how's your quit going? When was the last time you had a cigarette? Some kind of general question that will give you an indication of how long they've actually been quit. So you really want to very clearly monitor, very closely monitor those who've just recently quit. And I say, you need to be in at least contact with them every 2 weeks or so, right when they first quit. And even with long-term quitters, you can let them know about resources that are available. Book them into the quit line in your state. That's a very good way of helping to prevent relapse. You might want to also create a group in your clinic. So most of you, I think, are in clinics. So just kind of do like a support group, like a drop-in group, like an AA meeting kind of thing, where you advertise that that the group's going to meet at this time on this day, make that consistent every week. Then that allows people to know that there is some place they can go to if they need to talk. Now, you don't have to run this, or any of the clinicians don't have to run this. This can be one of the patients, this can be one of the residents that has volunteered to take this over. And then we're going to talk about motivational interviewing techniques to help you help them strengthen their coping techniques. And again, if you've attended any of these seminars over the last couple of years, we talk a lot about coping, and coping is learning to deal with the urges, desires, and triggers for a cigarette without having one. So how do you ask? I just give you some sample language here. You want to ask very clearly for everybody. Do you smoke or use any product that contains nicotine? Then if they say yes, here's some other questions to ask. You want to get more information about what happened. If they said no, give them a pat on the back. Say to them something like, I am proud of you. That's fantastic. Whatever you're comfortable with. And believe it or not, many people think that's corny, but actually it is really well received by the patient, and they really, it does help them to know that you've acknowledged that they've done a good job and that they've done something pretty significant. So if you have somebody that's just recently quit, as I said, you really want to monitor them. I think you should try to be in touch with them every 2 weeks. If you can, if there's some way to do that. If they are okay, nothing's happened, they stayed off cigarettes, congratulate them. If they're having a problem, then you strategize with them about how to deal with it. And another way to do this is to specifically ask, are there situations that happened in the last couple of weeks where you've been tempted to smoke? And then help reinforce the ability to deal with that. If they've successfully dealt with it, it's great to remind them of that and to remind them of what they did. If somebody's been quit long-term, you can still ask, now that COVID is going on, I know that you quit smoking a few years ago, but now that COVID is going on, have you been tempted to want a cigarette? And then again, look at if they've coped successfully, congratulate. If they have had a problem or they've had a slip, then you can ask these questions here, specifically strategize about how to deal with a similar situation in the future. So our whole point here is to prevent relapse. And this is the protocol that I've always used. Anticipate, plan, and rehearse. So know ahead of time what situations might be problematic, might lead back to smoking, might be tempting. Then create a plan to deal with that situation beforehand. And then I always tell the patient to practice. So rehearse what you're going to do, either actually rehearse it or role play it with somebody or role play it with you. So a good example here is you have somebody that quit smoking, 3 or 4 months ago, and you're talking to them and they tell you they have to go to a wedding. And of course, we don't go to weddings every week, or most of us don't. So this is a new situation that they're encountering where they used to smoke. So what I would suggest then is you sit down with this person and actually come up with a plan to deal with not smoking in that situation. So you might say to the person, okay, I want you to take a non-smoking person with you as a support person so that you have somebody to talk to. I also want you to take a break, so walk out of the reception and take some deep breaths every hour. Or visualize yourself at the reception ahead, before you go, in your mind's eye, seeing yourself successfully dealing with the situation without a cigarette, having fun, enjoying yourself, laughing, dancing, whatever. And then visualize somebody walking up to you and offering you a cigarette and you say, no, thanks, I don't smoke. So that's just an example of what you could do in that particular situation. So you want to take that example and apply that to any specific situation that a person is. You also want to focus on these 6 stress management skills as a prevention package. So I'm going to go over each one of them just very briefly. If people have good stress management skills, that usually then stops them from relapsing. I mean, think about it. If you're not 90% of the population in this country doesn't smoke, and they somehow are able to deal with stress. So they do something that's on this list. So if we're able to successfully do it, then our person who used to smoke can learn to do it. But you actually have to go over all this stuff or talk to them about it. So let's just go over these 6 prevention stress management skill techniques in turn. First of all, exercise. I think this is the best thing that you can get somebody to do. Now, in most cases, most of the people you're going to be dealing with, because this is most people who smoke, get scared by the word exercise, or they, I can't do that. They think that means joining a gym and spending hours and hours and hours doing all kinds of strenuous workouts. Not what I mean. And if you have somebody that you feel is going to react that way, just simply get them out walking for half an hour. I keep reading more and more and more data, more and more research showing that just a half-hour walk every day, at a nice brisk pace is enough to get the body going, get those endorphins going, and give you a lot of benefits. And that can reduce quite a bit of stress in and of itself. So any of these suggestions work. If walking isn't something somebody can do because of the neighborhood they're in, then see if there's something else that they can do. Swimming is excellent. If you want to join a gym, great. If you have the ability at your clinic to create a little exercise program, do that. Again, you don't have to run it, or a staff member doesn't have to run it. One of the residents, one of the patients can actually run it. They may have had experience with it in that area, and they would love to do something like that. Be creative here. Meditation. Again, you don't have to do a formal meditation program for this to work. Just simply taking 10 or 15 minutes by yourself in a quiet place, doing some personal prayer, or even just sitting quietly. Most of us nowadays don't do that at all. I think that's a great thing to do, maybe even before bedtime, first thing in the morning. Encourage people to talk to their priest, minister, rabbi, whoever that they have a trusted religious person in their life. That may help them in learning to deal with stress. Deep breathing. What we forget all the time is our people who smoke are expert deep breathers, because that's how you smoke. So that's how you physically do it. So they already know how to do the deep breathing. They just think they have to have this thing in their mouth in order to do it. So really work with them going through the steps about how to do the deep breathing without a cigarette. Again, they know how to do it. They just needed to be reminded. This is a great technique to do when you are meditating. It really does help build up some resistance to stress, and it's great in the moment. So if a person's having an urge, doing the deep breathing in that moment does help break the desire for a cigarette. Then we want to talk about coping techniques. So again, these are ways to deal with the desire, the trigger, the urge for a cigarette without having one. And these are both cognitive and behavioral. So cognitive, we're talking about changing how you think. So here are some actual sample language that a person can tell themselves in that situation instead of focusing on wanting the cigarette. I mean, think about it. What happens if we have a thought about a cigarette and we try to stop ourselves from thinking about it? I mean, think about that for 1 second. If you try to make yourself stop thinking about something, what happens? You think about it even more. So these are nice, easy to use mantras, if you want, just phrases that will prevent you from doing that and break that thought process and allow you just to move on. And my favorite thing to teach individuals, and I really think this is very important, is to remember, just because you think about something doesn't mean you have to do it, right? Because if every one of us on this call did everything we ever thought about, would either be dead, in jail, or dead in jail. Now, I know it sounds like I'm making a joke, but it's true if you really think about it. We don't have to do every thought. We don't have to act on every single thing we think about. So that's a very powerful realization that many of our smokers simply don't. Behaviorally, deep breathing, we talked about that. Just leave the situation. Say you're at the wedding and all of a sudden you want a cigarette because you see all your other friends smoking. Just leave the situation. Changing patterns and routines is very important. Most of our patients that we work with, their smoking pattern is very, very structured and happens in the same place at the same time with the same people. So changing those patterns and routines can break all that in your mind and get you away from wanting the cigarette. The fifth thing we can look at is a support system. So this is vitally important. We forget to help our patients create this, and I think we're missing out on a very, very powerful technique here. And so I always suggest right at the beginning when somebody quits is that they get a person at their work, at home, and within their social circle that they can turn to if they're having thoughts about a cigarette. And this has to be someone who will not give them any cigarettes, no matter what they say or do. You can start one of these support groups at the clinic, as I said. Just have a drop-in every Monday night at 7:30, or whatever works, or in the afternoon, or any time where there's not too much going on at your clinic. And then refer people to the Quit line. This is a great, great, great support system. It's free of charge. It's all done over the telephone. Every state has one, and the number is the same, 1-800-QUIT-NOW. It's also important in many, many cases that we help patients deal with their anger, because many times they smoked either out of anger at somebody else or to prevent themselves from getting angry at somebody else. So they use cigarettes as an anger management tool. So it's very important, again, to help them learn of other ways to deal with anger. So this can be another opportunity to do something at your clinic or to get them hooked in with a counselor for a short period of time. But I think it can be as simple as reminding people. I know I've worked with so many people who've said, well, I got so mad at my wife, I just started smoking again. I hope she feels guilty or something like that. And again, think about it. You're not hurting that other person at all. All you're doing is hurting yourself. So smoking is not a good way to get back at anybody. It's just hurting you. It's not doing anything to them. So maybe reminding a person about that could be enough to prevent them from doing it. And then finally, I want to really go into detail here about using motivational interviewing to prevent relapse. So we did have a whole session on motivational interviewing in our suite of trainings that we've done for the public housing people. So you could refer back to that. But I briefly just want to go into how you can use this in preventing relapse. So as a reminder, remember, motivational interviewing is a clinical style for eliciting from patients their own motivation for making behavior change. Remember this, we change behavior not because somebody else made us do it, but because we came up with the idea in our head. We can respond to somebody and they're nagging and hollering at us and maybe make short-term changes, but long-term change does not come about because of somebody else. It only comes about when you make up the internal decision to do it. So what we want to do is guide people to telling us they want to change or they want to stay changed in the perspective of relapse prevention, rather than telling. So you want to avoid all of these intimidation techniques, nagging, guilt, wagging your finger. Remember, people, if you do this, if you wag your finger at your patient, tell them they have to do this, who do you become? Their mother, okay? You become their mother, chastising the naughty child for doing something wrong. So do you want to be your patient's mother? Do you want to be your client's mother? No, I would guess not. So this technique, motivational interviewing, prevents you from getting into that sticky situation. But it also, think about this. How do most children react when their mother does this? They do this. They recoil, they refuse, they resist. So motivational interviewing helps also to prevent all that resistance, because you're working with the patient, not saying you've got to stop it. I've never told a patient in all these years that I've worked that they have to stop smoking. I work with them in a way to get them to tell me that they want to stop smoking. So the benefits of this, as I just said, are very clear, so I'm not going to reiterate on that. So what does motivational interviewing entail? Well, if you really want to learn this, it's a 3 or 4 day course. And of course, we only have a few more minutes here, so I can only go over some very, very important but basic techniques and basic premise of this. I did give you some references at the end here. If you really want to learn this, there are a couple excellent books, and there are all kinds of resources online where you can take classes. But on a very high level, you want to do 3 things. Accept ambivalence. You don't want to encourage it, but you want to understand that that's a natural state. Then you want to help the patient view change as a learning process. You know, I've been working with a guy recently here in Pittsburgh. It's now a month, and he has stopped smoking 4 times and started again. And he's getting very frustrated, but what I'm helping him understand is that this is not that unusual, number one. And number two, what did you learn about yourself in each one of those situations? Because my goal is long-term. You know, you have to think about this. Every one of us on this call knows how to ride a bicycle, I would assume, but none of us got on the bicycle the very first time and just whizzed down the road. We fell off, figured out what we did right, what we did wrong, got back on, and just kept learning and learning until we actually did it. So learning is a process. And part of this process is eliciting change talk. So that's what I'm going to be focusing on here for the next few minutes, is how to get the patient to have those words come out of their own mouth rather than us telling them what they need to do. So the goal here is to help them find their own motivation for change by making change more enticing than the current status quo. And in addition to that, helping increase the patient's belief that they can do this, because change is more likely to be sustained when the idea comes from the person, him or herself, not from you. Why do people keep a change going of any kind? Well, because it has value to them, and they are uncomfortable with whatever the old behavior was. They're comfortable with the change, with the idea of changing, and they feel that they can do it. How do people change? So this is very important. That's why do people change? How do people change? Again, generally, it's a process that occurs over time, not a discrete one-time. This is the stages of change model. I'm sure many of you are familiar with it. What's important for you to understand in terms of relapse and where we're talking about somebody after they've quit is they can cycle through this many, many different times, and even sometimes in the same day. So it's not necessarily a straight line where they're going from thinking about it to doing it to maintaining it. So realize that this is very fluid. And remember that just because someone quit doesn't mean they are going to stay quit. You know, I worked with transplant patients who, you know, were bound and determined to quit because the doctor told them that they had to. They wouldn't get the transplant. You know, here in Pittsburgh, the hospitals won't do a transplant unless you quit smoking, because there's really no point, because you're going to die of cancer a year or two later. So they'll quit. they have to, but that does not mean they will stay quit. So I really worked with them from the beginning to change that thought of I have to quit because my doctor told me to I want to quit because I want to have a good quality of life and live for many, many more years. All right, so what do you do here to maintain? Well, these are the 5 really big steps that you want to focus on when you're working with somebody. And this is either to get them to change to begin with or to stay changed. So even if somebody has quit, you can say, do you mind if we discuss your smoking status? Or can I tell you what concerns me? So you're asking the person right up front if it's okay to talk about it, rather than, we got to talk about this. Secondly, instead of telling somebody something, instead of telling them they have to quit, you want to ask open-ended questions. And these are questions that do not invite short or one-word answers. And most of these questions begin with 2 very specific words: what and how. So rather than saying somebody, you better quit smoking or you're going to die, ask, what would it be like if you had a stroke because of your smoking and had to lay in bed for the next 11 years like my grandfather did? Or how would it be if you had to spend the rest of your life lugging a oxygen tank behind? Now, while those may sound like I'm guilting somebody, I'm not. Guilting is you hollering at a person. These are asking them very specific questions to get them thinking. And they're asking them in such a way that they can't just say yes or no, or okay, or maybe. They have to elaborate on it. So you have an opportunity there. It opens up the opportunity for you to have a discussion with the person to get at what their motivations are and what their barriers are. Now, I don't really like the word why in this situation, because in English in America, the word why is really kind of accusatory, confrontational, can carry a lot of baggage. What and how can get you to the same spot without being that way. So here's some examples about open-ended questions. Somebody's telling you they're really, really tempted to go back because of COVID. So how would going back to smoking help you deal with COVID? Putting the burden on them to elaborate and give you an answer rather than you telling them something. Now, the most powerful question I think you can ask is, what would have to happen to you for you to consider staying quit, whatever the change is, but what would have to happen to you for you to consider quitting? And if somebody gives you a smarty answer like, well, I have to get lung cancer, because I've heard that from many, many people. Well, again, in the US, in our culture, in this day and age, everybody, many, many, many people think there's a pill for everything. So even if they get lung cancer, you can just take a pill and boom, it'll go away and everything will be fine. Well, that's not reality, folks. So asking this question and getting an answer like that can really help you find the flawed thinking that this person is employing and help them understand reality. 2 other techniques here, 2 other things you can use that I'm sure you're familiar with from many other situations is the importance ruler. So again, how important would you say it is for you to stay quit? And using this scale, you can look at, they'll say, well, I'm a 6. And instead of saying to the person, well, I think you're an 8, try to encourage them that way. Do it this way. Say, oh, well, you know what? From the conversation we've been having, I would have only said you were a 4. And then the person goes, well, what do you mean I'm only a 4? I really want to quit. So it's getting them to defend their position. And sometimes that ends up making them realize that they really do want to do this. And then same thing, how important is it? How confident are you that you can stay quit permanently? So again, the person may have quit because they had an illness or they got scared. We had a lot of people quit smoking during COVID. So the opposite of what we're talking about here, because they read correctly that if you were a smoker, you were more susceptible to getting COVID, and that it was much more severe because your lungs are weaker. So that may have motivated them to quit, but are they going to stay quit? If you have somebody that isn't very confident, then here's a wonderful question to ask. What accomplishment are you most proud of in your life? So the person says, well, I climbed a mountain by myself, or I paid for my way through school, or I raised 3 kids on my own. Whatever they say, whatever it is, your next statement is, if you can do that, you can stay quit. And again, you may think this is very simplistic, and in a sense it is. It's simple, maybe not simplistic, because this can have a very powerful effect. I've used this on many people, and you can just see the light go, the light bulb go off in their head, like, oh wow, yeah, you know what? I was able to do that, and and that was way harder than quitting smoking. So it's just this very quick, easy way to help them reframe what's going on up here. Looking at goals and values. So if you've worked with somebody a long time and you know them very well, you can look at this situation from that perspective. How does smoking fit in with your religious beliefs? How does staying quit fit in with your beliefs, etc.? Then you want to elaborate. So you want to get as clear and in-depth meaning of what is going on as you can. So again, these are things that are readily known, but I don't think you really think about them until you see something like this. So, just tell me more about this, or what exactly did you mean, blah, 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 or what exactly happened when you started smoking again? This is a real important question to ask, because I've talked to many people who think it's just like magic. One day the cigarettes showed up in their mouth and they were smoking, and they don't really take ownership about the steps that they took to get there. So this can help with that. Oops. Okay, got. All right, then you can ask about extremes. So I like this technique a lot. Let's say you started smoking again. What would your life be like next year or 2 years from now? Or the opposite, if you did stay quit, what would the rest of your life look like? What would be different? So again, getting them to think about what they really want. Listening reflectively is very important. So here you really want to use the person's own words. I hear you saying the idea of staying quit is very scary. Using the person's own words lets them know that you actually heard them. And then finally, you want to summarize. So you always want to give them some kind of summary at the end, either written or just in your verbiage. So here's some examples of what you can say. Now, as I said it a few minutes ago, you're going to encounter ambivalence. We know that. But that's not bad. It's kind of natural. The problem is getting stuck there. Think about it from your own perspective in your own life. You were probably ambivalent about almost every big change in your life, to some degree or another. So acknowledge that and help the person understand how to get past that. And you do that by using, again, I know you're familiar with this decisional balance sheet, but it works really well here. I find this very helpful to write all this stuff down, because the individual in their head, when you talk to them, says to you or thinks that they have millions and millions of reasons to continue to smoke and no reasons to quit. But when they actually write it down, they find that it's very difficult to find that to justify any reasons to continue, and they find lots of reasons to quit. So your goal here with all of this is, in the beginning, when we're working with somebody, helping them find a clear motivation to quit, but here is finding a clear motivation for staying quit. So it could be any of these things. You just want to be able to help this person find a very strong, clear rationale, because without that, they're unlikely to stay quit. And you really don't want to focus on death here. Okay. What happens if you focus on death is the person is bound to say to you, well, you got to die something, right? And guess what? They're right. You do have to die something. The fault here and the problem thinking here is that most people, when they think about dying from a smoking related illness, think they're just going to collapse on the floor. The angels will take them to heaven, bing, bang, boom, that's that. But the reality is it's in a very slow, painful, long, involved life before that death happens. So I never, ever really tell anybody they're going to die from smoking. I don't really get into that because of that reason. So again, it's what would it be like if you had to lie in bed for 11 years as a result of a stroke from your smoking? So it's those kind of questions that are really going to get them thinking rather than scaring them by talking about death. You can also be, I talked about creating a support system. Well, you can be part of that support system simply by letting people know that, understand that they have you in their corner and that you'll be there to help them in any way you can. I really, really, really encourage you to believe from the get-go that every single person you work with can change. They can quit. That's really important. If you don't think a person can quit, that's going to come across to them. So it's really important that you have that very firm belief. Now, the reality is we know most of them are going to relapse, but I go into every single situation with an individual feeling that I know you can quit. That really does help the overall situation. So that's how to prevent it. If it does happen, and it will happen, what do you do? Well, if relapse occurs, your role is to help them get back to abstinence. So first of all, you want to look at what exactly happened that they picked up that first cigarette. What was going on in their head? What were the steps that led them to go get the cigarettes? Where were they? That's a very good question. How did you get the cigarettes? Where did they come from? Once you know that, then you can look at specific coping strategies to help them learn how to deal with that situation should it occur again, because 9 times out of 10, it is going to occur again, whatever that situation is. So it's generally, dealing with stress or not dealing with it. So let's learn how to cope. I always ask, what did you learn about yourself during this quit attempt? And again, that really focuses them on the idea that this is a learning process. And then I renegotiate the quit date. So right from here, I say, okay, when are you ready to quit again? When can we do that? If they say no, my kid's in the hospital and he's going to be in there for 2 weeks and it's just too much going on, then say, okay, I'm going to contact you in 2 weeks and see how things are then. Don't just let it go. Have some kind of plan there to get a hold of them again. Now, if they're on a cessation medication and they've relapsed, what do you do? Well, in 99% of the time, don't do anything. Having a few cigarettes here and there, even if you're smoking, 4, 5, or 6 a day and you're on the patch or using the gum or anything like that, it's not going to negatively impact the person. Most people who smoke have such a tolerance for nicotine that smoking and using the medication at the same time is not going to negatively affect them. The worst thing that can happen if they get too much nicotine is they'll throw up, and that's that. Same thing if you're using bupropion or varenicline, just continue. In that case, they may not be getting enough medication, and that's part of why they relapse. So you might want to consider adding NRT to the bupropion or the varenicline. If they're using the patch, then you might want to add one of the short-term medications. We are going to do a webinar on all the medications in the coming months, so you can get more information there. But the combination therapies are the way to go. So if they're only using one thing, you may consider adding something else. All right, so final reminder here. Relapse doesn't necessarily have to happen. It can be prevented if you prepare for it ahead of time by strategizing about coping. So helping our person who's recently quit to learn how to deal with specific situations that they identify that might be triggers ahead of time, and in general to help them learn how to deal with stress ahead of time in whatever way we just talked about that would be appropriate for them. Number 2, boost their confidence. We talked about that, help them really feel that they can not only do this, but they can stay quit. So that's the whole point here, is staying quit. Excuse me, position quitting as a learning process. So again, it's not a discrete one-time event. It's something that happens over time. It's like learning anything else. Remember this, every person who smokes had to teach him or herself how to do it. It just didn't spontaneously happen. So you had to learn how to smoke. You have to learn how to not smoke. And then I would refer everyone to the quit line. That is easy to use. It's very powerful. We know it works. And it's free. As I just said, it's free. It's easy to use. And it's available to everybody. There are other resources. So if you have the desire to do this, look up in your neighborhood, in your area, what other organizations or groups are doing cessation. I know here in Pittsburgh, 3 of the hospital systems all have really good cessation programs. As you were told at the beginning, Dr. Leone said, I've trained 25,000 clinicians over all these years. Many of them have opened up their own practice or included cessation in their practice to see if there's somebody like that. The Cancer Society, the Lung Association have group programs. Find out what's available in your area and put together a fact sheet and hand that out to your patients who are trying to stay quit. And finally, all the medications that are out there do have their own support programs to go along with the medication. These are the references. As you can see, they're both Miller and Wolnick. They're the ones that really came up with the whole idea, the whole concept of motivational interviewing. The second one, motivational interviewing in healthcare, really does focus on how to use these techniques in any kind of healthcare setting, be it a dentist office or one of your clinics. So it's very appropriate and very appropriate. In addition to that, I would suggest you go online. Again, there's many programs out there that you can take that'll give you a much more in-depth understanding of motivational interviewing. But if you can't do anything else, start to ask open-ended questions rather than telling your patients what to do. That one change will make a huge change in what happens with your patients. And finally, this is my contact information. It is part of the deal here, folks, that you can contact me if you have questions about setting up a program in your clinic, if you have questions about an individual patient. More than happy to help you with any of those issues, big or small. So don't hesitate to call me. or contact me or email me. That is something I am very happy to do. So we have about 5 minutes left here. So if there are any questions, let me see, please come. Oh, so somebody asked, will the slides be available? Yes, I think Fide or Dr. Leone will tell you how to get them, but yes, they are available.
Thank you, Frank. If you would like to ask Frank a question, please submit it through the chat box or on your control panel, or use the raise hand icon in the reactions tab, and your line will be unmuted. Frank, thank you so much for this great presentation. A couple of announcements. Please make sure that you respond to this survey after this webinar. Your feedback is really important, and we would like to hear from all of you. Frank will be doing a couple of webinars in the next few months, so please visit our website, www.nchph.org, or you can also subscribe to our weekly digest, where you can find information about upcoming activities. But Frank will be doing a webinar on November 9th. This is concurrent treatment of smoking cessation and substance use disorders in primary care. This is a joint collaboration between the National Center for Health in Public Housing and the National Nurse-Led Care Consortium. Frank will also be doing 2 more webinars on smoking. One is going to be a webinar on medication for cessation. The other one will be cessation for individuals with psychiatric disorders. So please make sure that you visit our website and or go to or subscribe to our digest. Yes, the slides will be available for all participants. It will be sent via email in the next couple of days, or you can also go to our website and you will find the recording and the slides and all the materials that Frank shared with us. Please, if you have any questions, let us know. In the meantime, Frank, I have a couple of questions for you in regards to behavioral interventions for smoking cessation. You've been talking about all these behavioral interventions, and I have a question for you specifically in regards to COVID-19 and how COVID has changed somehow the way that we communicate with patients from in-person to virtual or communication.
Right.
So is there anything, Frank, that you've seen in regards to, I mean, you mentioned the quick line and the telephone counseling, but is there any internet-based interventions, or do you think that internet-based interventions can be considered, in cases like someone has a relapse?
Absolutely. There was a really nice web-based program that was run by the University of Boston, but they went out of business. I'm not sure why, but there is something called Become an X. So Become AN, the letter X. So Become an Ex-Smoker. That's the only thing that's online right now that has been validated and tested as successful. So they do have that program where you can actually get into like-minded groups of people. So if you feel more comfortable being, truck drivers can form their own group, or something like that. They do things like that. And but I really recommend the quit line. I think it's really important to interact with somebody verbally and to talk to them and help them so that they can really understand what your barriers are and where you need help, and then can give you some immediate feedback. So I really recommend the quit lines. They're very easy to use. I said they're free of charge. And the nice thing is that in many cases, they'll give you some of the medication like the patch or the gum or the lozenge for free for a couple weeks. So that's an added advantage there. They've tried some like text messaging programs. As far as I know, those have not really been successful because they're not really intense enough. But yeah, right now, the only one that is available that I'm aware of is it's called Become an X.
Thank you, Frank. Thank you for that information. One more question, Frank, in regards to how we are evolving. We mentioned the virtual visits, and another thing that is being, that I've seen in some literature reviews that I've done is social networks, and so how social networks are helping, those with chronic diseases.
Yes.
Have you seen any of these regarding to a smoking cessation?
Yeah, we've used that for years since the very beginning when I got into the field. We really recommend that you create your own social network amongst your family and friends, but even more so, like I said, the good thing about these clinics, your clinics, is that there have lots of people who maybe are quitting at the same time. So they can create a group at the clinic where everybody can meet and talk and support each other. So that's really, really important. And the quit line can be part of that too. If that person there on the other end can be a support person. But yeah, that's a vital part of this, and I think it's really important to have people around you that are giving you a pat on the back, helping you if you stumble, giving you some ideas about what to do. So yeah, definitely create a social support network on your own, and if you can in the clinics, with the people on the call now, help create that in your clinic.
Thank you, Frank. And we're at the top of the hour, so thank you so much, Frank.
You're welcome.
Again, those who have participated today, the slides and the recording will be available on our website. They will also be sent via email. And please don't forget our quick survey. Visit our website where you can find additional information on some of the HHS priorities, as well as other topics that we are providing or we are responding to based on the needs assessment that we have done. And thank you so much. If you have any questions, please visit our website. And if you would like to also get in contact with us, these are our contact informations. And thank you so much for being with us this afternoon. And have a great afternoon, everyone. Thank you, Frank.
You're welcome. Thanks, everybody.